will try and be heard, although I've got the microphone on. Can everybody hear me okay? Yeah. Today what I want to talk about, at least in the first 30 minutes, is insulins, something that often makes people's hair stand on end, and hopefully I'm going to clarify things for you. Just to recap and sort of make sure that we are all on the same page, let me just bring up this picture again that I drew the last time that we talked with each other, and remind you that the big message that I made at that point is that we have two sources or two different types of glucose that we rely on for our energy source. And in order for those two sorts of glucose to be used, the 24-hour drip from the liver and the sporadic source that comes from our food, our pancreas deals with it by providing insulin in two slightly different ways. We've got a basal insulin that's a 24-hour drip and a bolus insulin. We also talked about the fact that diabetes is when there is a disruption in this normal glucose metabolism, and hopefully the message that I got across is that there are multiple pathologies that contribute to the diagnosis of diabetes. We also reviewed the fact that we've got all sorts of different medications that have been created that have different mechanisms that are targeting the different pathologies that we've got for diabetes, okay? And the final point that I left you with the last time that we talked was the idea that if we wanted to replace the system, then we could provide two insulins, a basal insulin and a bolus insulin. And in fact, I kind of stressed the point that all we needed was two insulins to replace the system. So medicines are about patching the system up, and insulins you can think of as about replacing the system. So if we only need two insulins in order to replace the system, why do we have so many? Part of that is because of the history of the development of insulin, okay? And the other part of it is that we've got three companies making the same insulins competing for the same market. We've got Lilly, Sanofi Aventis, and Novo Nordisk. Before I go into the insulins, what I'd like to do first, however, is to redraw this picture in a slightly different way. Along here we've got time. And if we make the assumption that this person here that I'm going to talk about who does not have diabetes eats breakfast, lunch, and dinner. This is the evening, and this is when they go to sleep. And by the way, this is exactly the same way that I give it to patients who have got sitting in front of me. I'm not giving you any more privileged information than I give them. Up here, we're going to put blood glucose. All right? If I draw a line through this picture, which I believe we've done before, and I cover this side of the picture and we just look at this half, if we check a person's blood sugar when they wake up in the morning, we are looking at this side of the picture. We're looking at what is their liver doing and how well is their pancreas matching that. And in a person who doesn't have diabetes, what we find is they're going to wake up with a blood sugar of somewhere around 60 or 70. And if this person doesn't eat all day, then this just keeps ticking over all day. Insulin drip, liver dripping the glucose, and essentially the person would remain with a blood sugar of around 70 all day. But we do eat, and of course when we eat, we end up with this sporadic increase in our blood sugar. So every time we have a meal, we end up with a spike in our blood glucose. But of course, because the pancreas is working appropriately, our spike never goes above about 140. This is the normal physiologic glucose pattern of somebody who does not have diabetes. And in fact, if you think about it, it is also the normal insulin pattern in somebody who does not have diabetes. Because we've got this constant drip here of the liver that is being matched by a constant drip of the pancreas. And so matching this line, we've got an insulin drip. Every time we eat, we've got a bolus of insulin that goes out, and so we have a matching insulin bolus. And so this is also the normal physiologic pattern of insulin in a person who doesn't have diabetes. A little simplistic, but good enough to think about when we're thinking about insulin replacement. If you think about it, in a person who doesn't have diabetes, the physiologic pattern of the insulin is matching perfectly the physiologic pattern of the glucose. And indeed, the gold standard that we have for insulin management is to get our exogenous insulins, the insulins we're giving somebody, to perfectly match their normal blood glucose pattern. If there is a mismatch between the two, that's when you're going to get your hypoglycemic episodes or your hyperglycemic episodes. If you've got too much insulin on board up here to match the glucose that's available, the person's going to bottom out. If you've got too little insulin on board to match the spike in the glucose or any glucose, you're going to end up with a person whose glucose is too high. Any questions about that? Pretty straightforward. A nice way to understand the different types of insulins that we have is actually to go back and look at the history of how insulin's developed. And I'm going to go through this pretty quickly, and obviously I'm going to leave out some facts. But I think it does a nice job of actually presenting to you why we have different insulins and also how the different insulins work with their pharmacokinetics. It was in the 1920s, of course, 1921, when insulin was first discovered as the hormone that was so important for glucose uptake. And it was a year later that the first person received a dose of insulin in order to take care of their diabetes. And what they received was the insulin that was derived from crushing pancreases of cows and pigs. 1920s. Believe it or not, this was our mode of management until around the 1980s. Not a particularly good insulin. It was very impure. It was very immunogenic. But it was a huge breakthrough because for the first time we were able to keep people with type 1 diabetes alive. Having the diagnosis of type 1 was essentially a sentence of death. We didn't necessarily think about tight control. We didn't know it at that time, and we certainly didn't have blood glucose meters around, so there was no way of knowing what you were actually doing. Fortunately, what we were able to do, however, was to keep them alive longer and longer. Of course, we began to see some of the complications of poorly controlled diabetes. We didn't really understand them. Not only were we keeping the people with type 1 diabetes alive longer and longer, but somewhere around the 1950s, 60s, we were beginning to see type 2 diabetes rearing its ugly head. And believe it or not, at that time, the only thing we had to manage them was also insulin. And so we ended up with a bit of a shortage as far as managing to find enough pancreases from cows and pigs. And as many of you will know who are old enough, you will remember the bovine or the porcine insulins that we were using for these people. So there was a frantic, mad rush to try and do something. And fortunately, around 1980, somebody came up with the ability to genetically manipulate the E. coli bacteria, and we came up with the mimic of the normal pancreatic insulin molecule, which was essentially two polypeptides or two chains of proteins joined together by disulfide bonds. This is regular, as you know it, identical to the insulin molecule that we have in the pancreas. 1980 was when it first came out. The unfortunate thing is that when you put a whole lot of it in a little vial to give to somebody, the single molecule would clump together into 6 molecules called a hexamer. Unfortunately, when they're clumped together, they're not very physiologically active. And that's why when you give a person regular insulin, it takes half an hour before it's active because it has to dissipate into monomers before it will become physiologically active. I don't know how many of you are still using regular with your patients, or Humulin R or Novolin R, okay? But regular, you used to instruct the patient to take it half an hour before your meal. Half an hour to onset, approximately 1 to 2 hours for a peak. So if you gave it at a breakfast time, there was a little bit of a delay, and then it would take a little while for it to peak, and then it would last about 6 to 8 hours. Certainly a lot better than what we had with the porcine and beef insulins, but not a perfect match to a meal, which rises to a peak in about 30 minutes and also comes back to baseline in about 2 to 4 hours, depending on the content of the food. However, it was better than what we had. You can imagine quite a few hypos would happen when people were on regular. All right? Let me down here. I'm going to run out of space. So regular we tended to think of as being a bolus insulin, and it was produced by Lilly. It is a traditional insulin, and traditional insulins are ones that we believe of, that we describe as being biphasic, or having two parts to it. It's got a basal component and it's got a bolus component, so it's not a pure peak and it's not purely flat. Okay? So Lilly produced the first, we called it regular, or in Lilly's case we call it Humulin R. Do correct me if I use some of the wrong names, because we use them different names in New Zealand. And then of course we had Novo Nordisk producing their version, Novolin R, or Act Rapid is another name that they called it. Here is our molecule. They started fiddling around with it. They didn't like the fact that it would stick together, and they also didn't like how imperfect the shape was. They started adding bits and pieces onto the end of the polypeptide chains, and very soon after we ended up with our NPH coming out from this molecule. And essentially what this did is it extended the pharmacokinetics, or the basal component of it, and we ended up with an insulin that had an onset with a peak at around 4 to 6 hours, lasting around 16 to 20 hours. We think of this today very much as a basal insulin, even though it's got the basal component and a bolus component in it. Way back when I was a resident, we did used to try and use this bolus component, but these days we tend to use NPH very much as a basal insulin, is NPH. Okay, Lilly, we've got Humulin N, and Novo Nordisk, Novolin N. Pretty straightforward, right? We've only got two insulins, remember, a basal and a bolus. The confusion is about the number of companies producing these. In the mid-1990s, to go back to our timeline, the DCCT and the UK PDS came out, the mid to late 1990s, not that long ago. And of course what they came out with, unbelievable studies that changed everything, is they told us that tight control was incredibly important. We've got a problem if we don't have tight control. You can imagine with these insulins, it gets to be a little bit difficult when you have tight control. And in fact, if we try to use these in a basal bolus way, we end up with NPH. We often give it twice a day, maybe in the evening, to try and give us the basal that we want. You can imagine if we start pushing up the dose, you're going to end up with it going like this, and you're going to end up with times where you've got too much insulin on board. With the regular that we were giving, you can imagine it's hard to push up the dose without an awful lot of times where you're going to end up with people going into hypos. And indeed, when a person was on this kind of regime, we tended to very much prescribe what they had to do with their eating. These are the doses of insulin that you need to take. And by the way, you need to eat breakfast. You really should eat a mid-morning snack. You better have lunch, because we've got a peak coming around here. Mid-afternoon snack. You better have dinner. And by the way, you better have an evening snack, because you've got a spike that's coming along here. A poor match, and also 50% variable. So really difficult to tighten up control in a person with diabetes. And as you can imagine, we ended up with significant weight gains happening, which of course in type 2 diabetes, or in any diabetes, is not what we're wanting. So mid-1990s, the impetus to do something different, or to develop something different, was about the fact that we needed tight control without hypos. And so what the companies did is they went back to this molecule and they said, well, what can we do to stop it from clumping together? Again, Lilly was the first one to come out with Lispro. And essentially what they did is they flipped two polypeptides, a lysine and a proline. That's all they did. And what it meant was is it prevented the molecule from clumping together. So now they were able to put it in a bottle, and they were sitting in there as monomers, so when the person injected themselves, It acted immediately, had a much higher rise. It's not perfect. It drops fairly quickly, has a tail of around 3 to 4 hours. As you can see, a much better match to what we need for our bolus insulin. So that was Lilly. These are the analog insulins, and we call them analog because they've got one action. This has only got a peak component. It does not have a basal component. Lilly came out with Lispro. Soon afterwards, we've got Novo Nordisk with their Aspar, which you know of as Novolog. And then more recently, we've got Sanofi Aventis with their glulisine or their Apidra. They're all essentially identical in the way they behave in their pharmacokinetics. All right, any questions? So that was all fine and dandy, but we've got this problem with this basal insulin that doesn't do a great job. And what Sanofi Aventis was actually the first one to come out with their manipulation of this molecule. They not only flipped things in both chains, flipped polypeptides in both chains, they started adding on all sorts of rubbish to the ends, fatty acids and things like that. And essentially what they created for the first time was our basal insulin that we think of as being essentially flat. Not quite true, but it is essentially flat, an insulin that lasts for 24 hours. So Sanofi Aventis came out with their Glargine or their Lantus. Soon after that, Novo Nordisk came out with their Detamir. Okay, and Lilly does not have one. We now have the ability to completely mimic the normal physiology or the normal glucose pattern of a person with diabetes. Not only that, we have the ability, and I cannot stress this enough, to match each person's glucose pattern. How many of you don't eat breakfast? How many of you skip lunch? How many of you might eat dinner late? How many of you eat at the same time every single day? I don't reckon there's any one of us in this room that does. And yet for some reason we still seem to feel like we have to tell people with diabetes that you must eat your breakfast, you must have a little bit of a morning snack, and you must eat lunch, and you must do this, and you must do... Why? When we have the ability, actually, to be able to match insulin to their diabetes. And indeed, we can go further than that, and what I'll be talking a lot about when I talk about patient-centered care, we actually have the ability to hand over the information to the person so that they can figure out how much insulin they need to take with their eating pattern. We don't need to get tied up in fixed eating regimes. Questions? We've gone further than that, and in fact I've just come back from a week at camp, and we had a young girl on a trial, and she's on a new insulin that's about to come out, I imagine, given that nothing goes wrong with the trial, called Degludec. Remember I talked about the fact that at the beginning when they first took this insulin molecule, the frustration was the fact that they kept clumping together, and they spent an awful lot of time and money desperately trying to figure out how to get them apart. Well, with Degludec, what they have actually taken advantage of is the fact that it does clump together. And now they've created a molecule that is huge, where it's hundreds of insulin molecules clump together. It's very stable, and when the person injects themselves, it takes a long time for it to dissipate and release the insulin. And consequently, they have created a basal insulin that is incredibly steady and reliable and lasts for 3, 5 days, maybe 7 days. Are we going to be able to tell people to take 1 shot a week in order to manage their basal insulin? This young lady was on it once a day. They're experimenting. They're still not sort of deciding what is the best way to use Degludec, but it's pretty exciting news for a lot of people. I'm a little skeptical about the idea of taking it once a week or once every 3 days. It's hard enough getting them to remember to take it at the same time every day, but that should be coming out relatively soon. All right? On top of the fact that we've got different insulins, of course, we have developed different ways of delivering insulin. The insulin pump is essentially a pancreas that they wear like a cell phone. Many of you have seen them before. Please do get yourselves familiar with how they work. It's no different from anything we've been talking about, filled with a whole bunch of Humalog, Novolog, okay, or Apidra. And essentially, what it has done, it's been programmed to go drip, drip, drip for 24 hours, and then when the person eats, they hit a button, and it sends out the bolus of insulin. And of course, it's programmed to match what they need, their insulin resistance and things like that, so that they can even more closely match what needs to be done with insulin, with their glucose pattern, matching their glucose pattern. We've got throwaway insulin pumps, all right, and I'll be spending some time with the residents when I talk about equipment and things, used every 3 or 4 days. They stick it on, okay, and here is their control. In order to do exactly the same as the other pump, the advantage is that you have no tubing. We also have insulin pumps that now have continuous glucose monitoring systems, so that on the screen it's checking the blood sugar about every 5 seconds, and on the screen you get what your blood sugars are, and of course it can alarm you if your sugars are rising too quickly or lowering too quickly. We have closed loop systems not available in the United States, unfortunately with lawsuits as a possibility. It's very hard to get those started, but definitely in Europe we've got closed loop systems where we've now got the glucose monitoring systems feeding back into the insulin pumps so that the person doesn't actually have to be in the middle to intervene. All right? I'm still missing a whole bunch of insulins. I'm surprised somebody hasn't said anything. What about the insulin mixers? All right? Hopefully I've clarified why we have so many of the other insulins, but essentially there are 2 kinds. So what are insulin mixers? Insulin mixers, they've mixed a basal with a bolus, theoretically with the idea that they can reduce the number of shots that a person can take during the day. I find it kind of interesting because I think that they're a creation of us who believe that taking shots is a hard deal. Maybe some of us still believe that, but I actually think that people really enjoy the flexibility of a flexible regime. But what they've done is they've mixed a basal with a bolus. Initially what they did was they mixed NPH with a regular. And what we do is we mix it in a certain proportion, and so you end up with 2 numbers, 70-30. The 70 refers to what proportion of it is the basal, and the 30 refers to it as to what proportion is the regular or the bolus. So 70% in Humulin 70-30, 70% is NPH, and the other 30% is their Humulin R. Novolin have come out with another one, and then more recently we've got these still around, but we tend to reach for these because they're a better match, and we've mixed the NPH with one of these guys. Okay? Actually, they don't have a mix, but if we mix the NPH with the Lispro or the Humalog, you've got your Humulin 75-25. Is that what you call it here, or is it Humalog 75-25? Okay, so 75% NPH, 25% of the rapid acting. Okay, so they're fairly straightforward. And the message is that when you're sitting there with a person in front of you and you've got their insulins out and you're feeling a little bit confused about what you should be doing, take a step back and go, is it a bolus I've got with me, or is it a basal I'm trying to deal with? And that way you can begin to sort out which part of the picture, so to speak, that you're trying to address with the person. Obviously, if you're trying to address the basal insulin, the best time to look at their blood sugars is in the morning when they first wake up, because you're going to get the best match of how it's working at that time. Here's your basal insulin. First morning blood sugar is going to determine how you adjust that dose. And when you're looking at their basal insulins, you'd like to look at the 2-hour mark after the meal, or the 3-hour mark, to see how well the bolus insulin has matched the glucose. Any questions? I'll turn my microphone off. Any questions? Same thing, Humalog or Novolog or so you're trying to mimic